له علاقه بهذا لانه
اوكي
هو
احنا نبدي
يلا
بليز.
تفضل استاذ ميثم.
لايف على الفيسبوك.
اوكي
Okay, it's my great pleasure to be here with you. Welcome, everybody. We will start the sixth webinar of International Society of Health Education about COVID-19, thrombogenicity. May I ask Dr. Salman Al-Rawaf, the chairman of society, to start the webinar.
Thank you, Dr. Maydam. Good afternoon, good evening, good morning, wherever you are. And thank you very much for joining us in another session of our society. I think the topic today, and I'm delighted and we are honored to have Dr. Castro from United States with us to cover the most important topic under discussion within the clinical setting about the thrombosis which happen in the body. Yes, this is a respiratory disease, but indeed it's systematic and spread everywhere, causing thrombosis from the skin to the brain, to the heart, etc. We will have much more details looking at the clinical aspect of this and how to prevent it, how to deal with it from Dr. Castro, directly from his fantastic clinical experience. I will ask Dr. Haytham to introduce Castro, and we will listen to him, and then we will engage in discussion and whatever questions which we received from our clinical colleagues and the audience about this important issue of thrombosis during COVID infection. To you, Dr. Haytham.
Okay, thank you so much, Professor Salman. Hello, Dr. Castro, how are you?
Good afternoon, good morning, and good evening, depending on where you are in the world. Thank you for inviting me to give this presentation, which I think is a very important presentation, especially as an intensivist critical care specialist.
Okay, Dr. Castro,
Yes.
he will talk about the COVID-19 thrombogenicity in RCU patients. Okay, we can start.
Okay, thank you. Here we go. Here we go. There we go. And let me just do this. Okay, so again, today we're going to speak about COVID-19 and thrombogenicity. And when we talk about any disease process in general, but especially when we have a disease process that involves anything that has to do with sepsis, cytokines, cytokine storms, etc., we're always talking about the same organ system. And the organ system specifically that we're talking about today, when it comes to trying to understand corona-19 and thrombogenicity, is the endothelium, because that's where the disease really exists. When we talk about sepsis and we talk about any disease, especially when we deal with diseases related to a pathogen, an infectious disease, really we're talking about the endothelium, where everything gets generated, and we all understand what the cytokine source is, which is where everything happens. This is the engine of sepsis, we call it, or the engine of the disease process that causes us to develop all types of problems, but specifically what we're talking about today is with the activation of platelets and the other coagulation factors that lead to thrombosis. Now, when we talk about this activation, we have to understand that there also is a predisposition to these types of diseases. And those predispositions can vary on men and women and even children. And there is a genetic diversity, gender, age, any underlying diseases or comorbid diseases. Even the microbiome in the person's body plays a role. ethnic groups, whether the person smokes, consumes alcohol, and in specifically, finally, the virus itself. The virus itself has a role to play in all of these. So when we talk about cytokine surges and thrombosis, it's part of the multi-system activation process that can lead to end organs damage, and that can either lead to the death of the patient and, or if not, severe sequela that can last for the life of the patient. And again, in critical care, we always talk about the engine of sepsis. The engine of sepsis is the endothelium. And it is in the endothelium where we start this whole process of inflammation, and then also will ultimately lead to the thrombosis that we see in all these diseases, including coronavirus or SARS-CoV-2. This plays a role insofar as we are understanding up to this point with the ACE2 receptor. But it is when that coronavirus complexes to the ACE2 receptor that it sets off a cascade of inflammations and a cascade of processes that involve the bradykinin system, killikinin system, cytokines, et cetera, et cetera, et cetera, that all lead to damage of the endothelium itself, and with the ultimate predisposition to thrombosis. When we look again as to the actual process by which coronavirus itself initiates the process, it starts with number one, the viral attachment and infection, number one. We have the virus actually attaching to the ACE receptor. And it is at that point that initiates its first consequence, which is the initiation of an inflammatory process. And I am a big student of adhesion molecules. And one of the things that we know in critical care, specifically when it comes to adhesion molecules, we know that nothing starts without the adhesion, without the capacity to really link up and then initiate a process of inflammation. And so what happens is that once we get that inflammatory process going, we go into number three now. We have the activation of tumor necrosis factors and procoagulation factors, which include Van Willebrand's factor, which is actually produced and stored in the endothelium. And it is with this activation that we start the whole process of a neutrophil traps, which is actually a new science that's actually quite interesting, and also cytokine production. And with this process here, we start now the initiation also of the splitting of fibrinogen into fibrins, which initiate the clot formation. We have to understand that this is the initiation of the process, but in order to really start getting the aspect of thrombosis and also clot formation, we have to also get denuding or damage of the endothelium itself, which goes on to number five. Once we start getting the thrombosis, there can be two types of thrombosis at this point. It can be an endovascular thrombosis, which is the clots being formed in the blood themselves, and then they're carried along the circulation, or there can be denuding or damage to the endothelium itself that then will cause the thrombus to form right on the endothelial wall. So we have studied this process with coronavirus, and these processes, as we're learning, are once they are initiated, are follow pretty much the same pathway or the same mechanisms or pathophysiological mechanisms that lead to either thrombus formations, embolizations, and then thrombus formation with clotting of the blood vessels themselves. And depending on various factors, which we're going to review a little bit more, this process can be very mild. This process can be very severe. So it is very, very important to understand that this process starts in everybody, but it doesn't always progress to either major thrombus formation or embolizations. And this has to do also with those characteristics that we just saw about the genetics and other aspects of the virus itself. But again, when we talk about thrombosis and clot formation, remember that our mechanism, our body has a built-in mechanism for what we call healthy clotting. We clot in an effort to try to stay healthy or promote health. So the initiation process of this thrombosis or the clot formation is a normal process in our body. It's when either it's stimulated or produced or initiated in an abnormal way, and worse, when it can become out of control or it can become so severe that it causes what we call abnormal clotting, then we start having disease processes as a manifestation of the clotting itself, meaning thrombosis, leading to either vascular and either arterial or venous occlusion, and also embolization that can lead to embolization in other parts of the body. And remember that if a clot is formed and it embolizes, it can also initiate a thrombotic process wherever it finally gets logged. So remember, what we're really talking about is the normal process of clotting that has become abnormal in the coronavirus disease process. And we have been able to elicit what ultimately happens. What ultimately happens when the coronavirus gets into our body, gets into our lungs, and it is in our lungs that when it attaches to our ACE receptors, that initiates this coagulation cascade in activation. But there are a lot of other factors that come into play, as we mentioned earlier. It is the thrombus, the erythrocytes, the neutrophils, the platelets. It is also the cytokines, and more importantly, the adhesion molecules that are located in the vascular bed of the lung that ultimately lead to thrombus formation, embolizations that can lead from everything to deep vein thrombosis, to strokes, to also thrombus into the heart, and all in situ thrombosis in the vascular bed of the lung itself, pulmonary embolisms of sorts. But remember, all of this first initiates with the inflammatory process. It initiates with the inflammatory process at the sites where the virus enters our body and initiates this aspect of thrombosis and hypercoagulation. When we look at more specifically at the normal lung, we know that there is a process of normal endothelium with normal blood flow and normal passage of oxygen in and out. But when we get the coronavirus latching on to the ACE inhibitors, we start initiating a process of inflammation that also involves what's called neutrophil extracellular traps. This is a process that we know that tends to develop some of the most hyperactive inflammatory process in the local tissue of inflammation. And also it can lead to damage to the endothelium, and which exposes the collagen underneath, which can lead to platelet adhesions, clot formation, microembolizations, D-dimer gets split off, and then we start seeing a whole process of either in situ thrombosis or microembolizations that can lead to major embolizations. But again, what are the specific mechanisms? How does coronavirus itself cause this thrombosis? Well, we know that, again, people who have coronavirus disease are very similar to other infectious disease infections that we see in other patients. And there has to be not just the coronavirus itself causing the thrombosis, which it can, but it also has to be do with pre-existing conditions that predispose the patient into these diseases. And as we start stratifying all the cases around the world as to whether were either the pre-existing and or comorbid diseases, we'll start learning how the patient's ambulatory capacity, genetics, production of fever, diarrhea, liver injuries, kidneys, heart failure, and other coexisting malignancies will play a role into the clot formation. We do know again, and it's very important, that the inflammatory response is at the level of the endothelium, and it ultimately becomes an endothelial dysfunction that's superimposed on the infection. And this is a very important concept because, as we all know, coronavirus's major method of morbidity and mortality is through this superimposed endothelial dysfunction that predominantly involves interleukin 6 and other inflammatory processes like C-reactive protein. When we look into the hemostatic, or if not the blood-related abnormalities that we see associated with coronavirus, we know again because of the in situ inflammatory process, we start seeing pulmonary microthrombi, which can ultimately lead into major pulmonary type thrombosis. and also intravascular coagulopathy associated with the DIC that we see generated in the thrombi in situ, that can also lead to myocardial injury, and that can lead to cardiac markers. And then we can also see all these D-dimers in our blood parameters going up. And also we start seeing platelet consumption, and we see that our platelets coming down. We are still yet to determine whether there is adhesion problems with the platelets after the cytokine surge exists, but we do know that there's a massive consumption of platelets. And again, this ultimately leads us to the clinical outcomes, which cause venous thromboembolism, myocardial infarctions, and then we end up into severe disseminated anticoagulation, which are the clinical manifestations that we see. But besides the actual virus itself linking up with the ACE receptor, another stimulus for the thrombosis is what we call the local hypoxic damage that we see. In the alveoli itself, we know that this inflammatory process that we see in fluid accumulation in the alveoli causes a severe reduction in the local oxygenation capacity. This severe hypoxia itself will lead to local ischemic events that can ultimately lead to also distal effects. And we know that when we talk about hypoxia, it's a major, major damage. Many people and many patients specifically always ask me, Dr. Castro, as long as the saturation is over 90, we're okay. But what if it's 88 or 89? I say to them, it's very dangerous because, as we all know, saturation is really just a marker of how much of the total hemoglobin in our blood is saturated with oxygen. And that's really not what we're concerned about. What we're really concerned about is the dissolved oxygen in the blood, which is called the PO2. That's not even what we're really concerned about. We're more concerned about the oxygen in the mitochondria. So when you see that a saturation of 90 really means partial pressure of oxygen in the blood of 60 millimeters of mercury, that actually represents 2 to 4 millimeters of mercury oxygen pressure at the level of the mitochondria. So when we see that stratification, we can see that if we go from a saturation of 90 to 89 or 88, our margin of error at the level of the mitochondria, which is a partial pressure of 2 or 4, can go down to 0 very quickly. That's why people, when they go down to a saturation of 88, 87, they are essentially having ischemic events throughout their whole body. And those ischemic events will lead to thrombosis and coagulopathy. Again, just as a quick review, we know that the intrinsic pathway and the extrinsic pathway are involved in the process of coronavirus. But studies have shown that here in this diagram, we see the areas that are shaded, the shaded areas are the areas that we see that are activated more so in coronavirus processes. So we sometimes do not see the starting points of the coagulation pathways, either intrinsic or intrinsic, but we see that midway into the clotting pathways, we see activations at the level of fibrinogen being converted to fibrin. Platelet activation itself with the consumption of platelets. We also have a tissue plasminogen, TPA, being converting plasminogen to plasmin. So we see that there's marked stimulation and activation at the lower levels of the coagulation profiles, which make coronavirus a very interesting disease, because we know that even though, as we're discussing today about clotting and thrombogenicity, the reasons why we're learning that this is happening lower down at the level of the clotting pathways is because there's also an immunological component to this also. And again, as we see coronavirus causing this damage at the level of the endothelium in the lung, the tissue damage, that essentially sets up a whole inflammatory and cellular destructive mechanism that activates the clotting factors, and that initiates the formation of fibrin, which causes the thrombosis, and then ultimately leads to all the other aspects of disease management. Now, and why is this important to know? How coronavirus and along where in the coagulation coagulation pathways, it causes clots, because that will have significant therapeutic implications. Because we'll see that maybe there are certain anticoagulants or some other medications that will help prevent this type of clotting to occur in our coronavirus patients. And again, the coronavirus and the link to coagulopathies is linked to the vascular inflammation again. Again, that endothelial dysfunction, that endothelial damage that is initiated by the virus connecting to the endothelium through the ACE receptor that sets off a whole host of inflammatory factors. But one of the most important ones is the adhesion molecules. And we're learning that ICAM1 and integrin is very instrumental in this process that can lead to all the clinical disease markers that we see in coronavirus. And again, the abnormal clotting will be determined by the disease severity, because we see that depending on how severe the infection or the inflammation presents in a patient, we will get significant amount of abnormal clotting. And we're trying to find a correlation. Are people who are clotting or having coagulopathies having more issues with the virulence of the virus, or is it the component that is causing more inflammations and also more thrombosis in a particular patients and not in others? And as we learn the pathways, and we know that the cytokine storm is at the center of it, but remember the cytokine storm has various components with it that include the clotting cascades and also the adhesion molecules besides the regular cascades of thrombosis. And the reasons why the adhesion molecules are important is because no cell will stop in a site of inflammation and cause more inflammation if it doesn't have a handle to hold on to. We know that the coronavirus links up with the ACE receptor, but our inflammatory cells link up to that area through the adhesion molecules. And there seems to be an increase in expression of adhesion molecules that are present in this inflammatory process, because it is through the adhesion molecules that the rest of the inflammatory cells, leukocytes, macrophages, etc., will link, roll, connect, and ultimately go into the endothelium to continue that whole process. And we are learning right now which are the specific adhesion molecules that are involved in this. And again, this is very important, because if we can prevent recruitment of pro-inflammatory cells into the site, not only will we prevent destruction at the level of the endothelial basement membrane, but also reduction or elimination of thrombosis. And again, the components of the coronavirus infection are inflammation, adhesion molecules, coagulation pathways, then the activations of complements that again involve thrombosis and ultimate expressions of pro-inflammatory factors that lead to thrombosis, and then the ultimate recruitment of inflammatory cells. So we are slowly breaking it down to the three components that lead to the inflammation, and they can all lead to the thrombosis that we see associated in coronavirus. And again, one of the principal sites that we have to understand is that the adhesion molecules are not just important when the coronavirus itself links to the ACE inhibitor, but also the hypoxia caused by the coronavirus causing inflammation and flooding of the alveoli. The hypoxia itself will cause upregulation of adhesion molecules, which will predispose to more inflammation, more endothelium and collagen exposure, and more clotting. So we see the thrombogenicity being associated directly with the coronavirus linking up to the ACE inhibitor, but also we see that the hypoxia itself will predispose the endothelium to promoting more inflammation and thrombosis as a result. So in other words, the hypoxia through the upregulations of the adhesion molecules will continue. As we study the inflammatory and the cytokine surges in all these diseases, we see that the coronavirus has a similar pathway of surge, sepsis, septic shock, multi-system organ dysfunction, and either it causes death or recovery. And we start trying to identify at what point can we intervene? At what point can we either minimize or stop the whole process? And that is why it becomes very important to understand how this endothelial damage can lead to surge and ultimately thrombosis, and then hopefully be able to intervene and prevent the clinical course from going to its full extent. There are a lot of ways that we can determine how coronavirus is causing the inflammation. Is the patient at a higher risk of thrombosis, and how much inflammation? By using all the well-known blood tests, the D-dimer, fibrinogen, platelets, PT-PTT, leukocyte monitors. We can even measure factor VIII soluble. We can even measure soluble P-selectin, which is an adhesion molecule that's very important for white cells to be recruited and complement cells. So we have a whole host of blood tests that we can measure on the patient to see which ones are either more predisposed to thrombosis or are having more thrombosis, so that we can mitigate that process of thrombosis and ultimate mortality. And again, we know we have a whole host of pharmacological modulators that can prevent directly or indirectly the endothelial activation that is mediated by that leukocyte recruitment. And that leukocyte recruitment, remember, is by the upregulation of adhesion molecules, the VCAM1, tumor necrosis factor alpha. And we also know that P-selectin is involved. And we do have some medications that we are studying right now to determine how we can attack PCAM1, E-selectin, P-selectin, and all the other mediators of inflammation. And then we also have specific therapeutic modalities to either prevent or treat the thrombosis that we see in these patients. Obviously, heparin, and we see all the rest of the low molecular weight heparins that we have in place, and including the corticosteroids that are very important for the blocking of the inflammatory process and immunomodulating the person to not create such a severe inflammatory response that will cause thrombosis. So we have ways that we can prevent the cells from being recruited. We have ways to either minimize or treat the thrombosis. And we also have modulators that work directly at the level of the killikinin systems in an effort to try to work. And some of them are well-known medications, just like losartan, that work along with the enhancers of ACE prevention, blockers, and we looked into mitigating the interleukin-6 receptors. So we are studying a whole list of medications that will help, and including the signaling, inhibiting the signaling that occurs at the level of the endothelium in coronavirus infections, which are these newer medications that help prevent that rage or that cytokine surge that we see in a lot of the clinical patients. And again, more specifically, the interleukins, the ones that also participate in the inflammatory process. We have a whole host of new medications that we are studying to determine if we can use this. Ultimately, we know that it will most likely be some type of a cocktail in these patients. But along comes in also the monoclonal antibodies. We have a whole host of different types of monoclonal antibodies that we're studying, again, to minimize the cell recruitment and activations. But again, a big, very important aspect of it is that activation of the ACE inhibitor by attachment by the coronavirus will lead to the start of this whole process, besides the viral infection right now. And we are also studying soluble ACE2 that is genetically engineered. And by administering to the patients, we can block the virus itself from initiating the whole process on itself. When I was a pulmonary critical care fellow in the early 90s, we used to do bronchoalveolar lavages of patients with PCP pneumonia, and used to lavage the lungs and measure the soluble ACE levels, because that we understood in that disease was one of the major drivers of the cytokine surges. And we are now capable of, with the soluble ACE that's being administered to some patients, to be able to block the coronavirus from even attaching to the ACE receptor, and hopefully preventing, or if not minimizing the inflammatory process. Again, from a clinical perspective, patients that are severely ill with coronavirus present very similar to patients that have severe sepsis. They become coagulopathic, and that coagulopathy can be either increased thrombosis or hemorrhaging as a result of severe inability to form clots. But the predisposition of dehydration, volume shifting, we in critical care, we measure something that's called lung water content. We know that there's a great flooding of the lungs, and that in of itself creates a whole process of inflammation, regional inflammation. In critical care, we've been for many 20 years trying to do regional oxygen studies, because we know that if we do oxygen studies on the patient in general, they might look good, but there will be various parts of the body that are hypoxic. And this is important because we know that local hypoxia will also lead to this inactivation. Again, I thank everybody for the opportunity to present this very important study. I want everybody to understand that the basic treatment of the thrombosis and or coagulopathy is very basic. We've been doing it for 30 years, but coronavirus is presenting us with new challenges because of its mechanism of how it causes the coagulopathy. And as we understand better the pathophysiology, we'll be able to intervene at various sites of the coagulopathic pathway. Thank you, everybody.
Okay, thank you so much,
Thank you very
Dr. Hector, about this interesting lecture about COVID-19 thrombogenicity in ICU patient. Now we have the open discussion. Anyone want to discuss further point with the speaker?
Can I ask a question, please?
Yes,
Uh,
Majid, can I ask a question, please?
Okay,
go
okay,
ahead.
Dr. Majid, you can ask Dr. Hector. You have any question?
Very much, Hector, for a very, very detailed, lovely illustrated talk. Even I'm sure will be understood by even the layman, let alone professionals. Thank you very much. This is such an important topic and contributor factor to mortality. Can I ask you, please? You gave a very wide range of investigations in order to guide you to the mechanisms in order to intervene. My major concern, and we are talking to Iraq and other countries with limited resources, except for example, D-dimers and common coagulopathy mechanisms. What would be your advice to do, how to manage? I mean, would you intervene in every patient? Would you take each case on its merits? Would you be guided by certain common factors? Thank you.
That's an excellent question, and thank you very much for asking that, because yes, we can sit here and look at the science and look at the molecular genetics of it, but the reality is not everybody in the world has access to doing these tests or, God forbid, even treating. And I'll be bluntly honest with you, what we have been doing here in the United States and also with my colleagues around the world, taking it specifically that concern of in some regions of the world, even here in the United States, we don't have access to the treatments. We revolve our anticoagulation efforts around two medications, which is the corticosteroids, preventing the inflammatory, immunosuppressing the patient so that they won't even start the thrombosis process. And also, we've been using non-steroidal anti-inflammatories. I know that in France, at the beginning of the epidemic, there was a comment made about non-steroidal anti-inflammatories not being good for coronavirus patients, hence the reasons why people were being given other medications, including Tylenol. To this day here in the United States, even though studies afterwards showed that that was not true, even here in the United States, we still have patients going to the emergency room. They're not sick enough of coronavirus. They're told to go home and take Tylenol and being exposed to high doses of Tylenol. So we've been using a combination of corticosteroids. We've had excellent results with prednisone. I'm not, I love dexamethasone, but we've been getting very good results with prednisone and non-steroidal anti-inflammatories. Now, remember, one dose of non-steroidal anti-inflammatory lasts 7 days, which is the life of a platelet. But what we've been doing is we've been combining that with the anti-inflammatory, antipyretic, and antiplatelet component, and at times for the first 2 days giving anywhere from 200 to 400 milligrams of a generic anti-inflammatory every 4 hours for 24, 48 hours, and then tapering off to maximize the antithrombotic and anti-inflammatory component.
Okay, thank you so much, Dr. Hector. Now, Dr. Al-Wazan.
Yes.
Welcome to Dr. Al-Wazan. If you have any question to Dr. Hector.
Hi, Dr. Hector. Thank you very much for the nice briefing. I really enjoyed it. So when we can clear the patients, like, there is a time frame that we can say 1 month post-infection, 2 months, like when we can clear these people, because the thrombosis can happen like maybe 6 months afterwards. So when are you gonna have to say this patient's enough of, thrombolytics, you can go home, you're fine, you're safe. Thank you.
Again, another excellent question. Another excellent question. And the problem is that we don't know.
Sure.
This is a new infection. We have no idea how a patient is going to respond. And because there's so much variability, because we do understand that there are genetic predispositions and environmental predispositions. So we have to do what's very difficult to do, is we have to follow up on the patient. We have to follow them carefully. And unfortunately, that's not something that logistically is possible in many concerns. So then the question to be begged is, will there be a need for some long-term anticoagulation treatments in some patients? But then again, the question is who? And as we study more the pathophysiology, hopefully we'll be able to identify who will benefit from long-term management or preventive anticoagulation management, because there will be people who will thrombose 6 months later on. In critical care, our concept is it takes 1 year for somebody to recover from a critical illness.
Okay, thank you. Another question from Dr. Seema.
Yes, good afternoon to everyone. Good afternoon, Professor Matham. Good afternoon, Dr. Castro. It's great to see you. It was an amazing presentation, as always, when you speak. And I actually have 3 questions for you, but I'm going to ask the first one, which I think is a little more extensive. My question is, when we are dealing with patients, with coronavirus patients, and of course, there's a very high risk of formation of thrombi, we want to prevent not only the complications of the coronavirus itself, in terms of the upper respiratory tract and the lower respiratory tract for that matter, but we also want to prevent thrombogenicity. So how would you, Dr. Castro, look at a combination of treatment using prednisone, Contact, which is another non-steroidal anti-inflammatory medication many people are not mentioning, and Eliquis?
Well, again, that's a very clinical question. And I know you're a Seema, that you're a cardiothoracic ICU specialist.
Yes, yes.
The reason is this, that see, I'm a purist, meaning that I first like to understand the underlying process and then find out where I can clip and stop. We can also look at it from a perspective of just doing an overall treatment modality of just blocking everything. For example, as Dr. Rosa Ragal was alluding to, the fact is that we don't know. We do know that, for example, the heparins, even though they're excellent in anticoagulation, but they have a high risk of interarterial thrombosis. And so we don't know how the coagulation cascades are going to go. a simple understanding will be that you have an elderly person who is hospitalized in the intensive care units for sepsis. They recover, they go home, they're fine at home, and 3 months later, they die. There's a lot of things that we do not understand in the pathophysiology of these diseases. And so I look at Dr. Rowe's comment as being very important, because we will have a lot of long-term, not just mortality and mortality, and we have to follow up on these patients. And one of the things that we also have to look at is doing autopsies. Without doing enough autopsies, we will not fully understand the disease. And unfortunately, we don't do autopsies in general.
Thank you.
Dr. Rose, I think you had another question.
Yeah, I do. So most of the patients, the old people, are on aspirin. Does the aspirin work? Can we rely on just aspirin? Because you can't, risk the lives of these people and give them, heparin or warfarin. It's so dangerous,
Yes.
So
Yes.
what we can do, I mean, if the aspirin works, we can put everybody on aspirin for forever.
Yes, and again, that's an excellent question. Now, when we have patients that are not overdose, but are under the influence of an antiplatelet like aspirin or any other non-steroidal anti-inflammatory, and we want to reverse it, there is a reversal most people are not aware of, is by giving them desmopressin or DDAVP. And we give them either 6 micrograms or 13 micrograms, no more than twice a day. We actually release Van Willebrand's factor from the endothelium and override the permanent inflammatories. And it takes 24 hours for that endothelium to regenerate enough to cause another thrombosis. So, and to asking you right now, and this is why initially when we were saying, okay, we did have a lot of people on aspirin, so they should be fine, maybe. But we decided to go on the higher end because we weren't sure with the inflammation that was happening with these patients at the level of the endothelium, how their Van Willebrand's factor was participating in this pathophysiology. So Van Willebrand's factor will compensate and still cause platelet adhesion. But again, it's very difficult. Should we put people on long-term antiplatelet therapy? Should we put them on low molecular weight heparin? It's an excellent question. We don't know. We don't know. Because they also causes a lot of other potential side effects. Dr. Salman, you're on mute.
There is one factor. Thank you very much. Great. It's on the mind of clinicians and people in public health and planners that these the physiopathology and endothelial changes is happening in all cases of COVID infection, whether it is mild, moderate, and severe. But the body reaction and actually the cytokinic storm is the cause of more severe damage. So we don't know whether these mild cases may have long-term damage or not. I mean, that is really the critical question now, because this virus is unbelievable and we hardly understand much about it. And I don't know what is your views about mild and moderate cases and indeed the potential of thrombotic changes in the future.
Well, again, very, very excellent commentary and question. And again, it goes back into what Dr. Rose was alluding to, which what should we do when they can go home. We do know that there are a lot of genetic operons that are activated through any disease process. We don't, and it's because of the limited resources that we have in regards to actual therapeutics. If we don't have a treatment for it, we don't consider it important because we can't treat it. But in this type of infections, we don't know if there's a genetic manipulation or modulation that happens that might be permanent in some patients.
Yes.
One of the things that I teach my critical care fellows is that our body is constantly renewing itself, including the genetics. And so and our body still that might essentially it's changed the physiology of a person. But because in practical clinical medicine, once the patient seems good, we don't continue testing. So we never really determine if a person is altered permanently that might actually predispose them to other diseases. But I think that as we learn more about coronavirus, we'll learn more how this virus, through its inducement of the cytokines, teach us one thing that we've always known in critical care, that all these diseases are endothelial diseases, and that ultimately all diseases are actually infectious diseases. For example, we know that cardiac thrombosis, when you have a heart attack, is not because necessarily of high cholesterol. It's because there's actually a chlamydial infection at the level of the endothelium that then causes the cholesterol to cause thrombosis. So we know that infections and infectious diseases are very important, and they somehow play a very significant role, short-term and long-term.
But that begging another question, Hector, here, linked to that, because one of the observation among the so-called long COVID, I mean, there are other terminology, that these people, let us call them patient because they still suffer something, although they are recovered clinically, but many of them reported that they are sleeping very long hours, 10, 12 hours. And this is honestly something may affect their vascular system somehow, including the brain, including the heart, etc., that the body feels tired. It needs longer recovery and sleep, especially among adults, which is normally 6 to 8 hours. Those people sleeping 10, 12 hours. It's interesting, Peter Piot, which is well known, the one who discovered Ebola, in an interview with the editor of the JAMA, was talking about this phenomenon of sleeping long hours. Love to hear your views on this.
Well, that's very interesting because, again, I'm old enough, and some of us were old enough to remember when the AIDS epidemic started, that initially it was a straightforward disease. Then we saw, oh, AIDS just affects the T4 cells. Yeah. Then after a while, we realized it infected every tissue in the body.
Yes, yes.
We're starting to find that out about coronavirus also.
Yes,
yes. And nobody really is looking at the adrenal glands because nobody's realizing whether these people are having dysthymia, CNS dysfunctions, and also something that have always been a major of interest to me is the microbiome. How is our microbiome, especially our intestinal microbiome, affected at the moment of infection or long-term? And that plays a role. Remember one thing, that there are people here in the United States, and I'm sure around the world, that sometimes get arrested because they're driving while they're intoxicated, but they never drank. That's because the alteration in the microbiome causes them to ferment alcohol, and then their blood levels are high. So we have to understand that the physiology with this virus is changing tremendously, but also we have to understand how our compensatory mechanisms are changing, including our microbiome.
Okay.
Thank you.
Dr. Yusuf, you have a question? Dr. Yusuf?
Hi, it is good to see you again, Dr. Hector. Thanks
Hello,
for your nice,
Joseph. How
interesting talk. Hi, how are
you?
Can I share my screen?
Yes, you can.
Okay. Now it's sharing, right?
No.
Or not yet?
Not
it's
yet.
sharing?
No.
No.
You are a co-host. You can sharing. If you cannot,
Okay.
you can.
Now it's sharing, right?
Yes,
Yes.
yes.
Okay. I just want to remind about a fact published, I think, 1 year ago. Heparin is not just anticoagulant in COVID-19 patient. It's also impede the thrombogenicity. I mean, it is not just impede the thrombogenicity, but heparin inhibits SARS-CoV-2 virus spike protein by reducing the virus ability to attach human cells and infect them. So you think this is proved clinically, Dr. Hector?
That's a very interesting comment that you made, because we are finding a lot of repurposing of these types of medications. It's like, for example, we're not testing for it. That's the problem. There's a reasons why we're using azithromycin or the erythromycin medications also similar to this, because actually the studies were done with Ebola, in which erythromycin prevented the Ebola virus. But once it entered the cell, it prevented it from shedding its capsules so that it can liberate its genetic information. And we're finding the same thing with coronavirus. So this is quite true that heparin has this capacity, but the problem with it is that nobody's checking. We're not checking viral loads the way we should be. We're not even doing autopsies. So, and it's very complicated, because remember, a lot of our resources right now are being diverted to just cure and saving people. But this, Joseph, is an excellent statement of saying that there are a lot of medications that, as we learn more about the pathophysiology of the virus, that we'll be able to repurpose some medications. And that's one of the reasons why we use the macrolides. And I prefer to use, just as a comment, I prefer to use clarithromycin and not azithromycin because of that reason. Azithromycin is an excellent medication because it preferentially concentrates inside white cells. But we don't need it just there. We need it everywhere. So that's why we prefer to use clarithromycin, that has an even better spectrum of activity, but it penetrates all tissues much more easier, and we're getting some pretty good results.
Okay, thank you. You said, as we know, there is a list to test the thrombogenicity. I think in addition to the list, the most important on the list to test the thrombogenicity is the clinical examination, the serial clinical examination, day by day, hour by hour. And there is a classical example of one with the respiratory distress due to COVID. We concentrate on lung and on respiration. And we covered his legs hour by hour ischemic, and we don't know until late discovered. This is I think, an important issue. I want also to share with you a paper we already published. It's by me and my colleagues. It's sharing, the screen sharing, right?
No.
No, it's not now.
Hello?
No. Not yet.
Not sharing?
Yeah.
No.
Okay.
Okay.
Now it's sharing?
Yes.
Oh, okay. Paper by me and my other colleagues. It's acute limb ischemia in COVID-19 patient retrospective study. It's a 400 patient COVID-19 patient. The incidence of acute limb ischemia in those 400 is 5.25% compared to the usual, which is 1% should be in this 400 person. So, and those patients sustain different modality of treatment, from conservative to interventional surgical embolectomy, and I think in two of them there's already dead limb. They did amputation for them. So clinical examination is very important to monitor and discover early things like this acute leg ischemia.
Well,
Yeah.
that's an excellent paper,
Yeah.
but it represents your background as an intensivist also, because you have to constantly be monitoring the patients. And one of the problems that we're finding is that it's because of the limited amount of physicians or professional medical workers we're doing a lot of telehealth. And as a result, we're really very superficially managing these patients, and we're missing a lot of these things. But
yeah, and I think that,
yeah,
a question asked by some of our guests about for how long the patient post-COVID should take anticoagulation, even simple anticoagulation like aspirin. I think no study said for how long, right?
Nobody
Right?
said. Yeah, nobody.
No,
because,
nobody said.
No, nobody said, because we don't know.
Yes.
But like you say, Joseph, if you are evaluating the patients on a regular basis, then you'll be able to identify those that should merit it. Here in the United States, in New York City at least, Mount Sinai Medical Center has established its COVID monitoring unit, very similar to the same unit that we established after 9/11 for monitoring the patients that were exposed to all the dust that they exposed to. So be monitored on a monthly basis. And that requires a lot of resources, and some places don't have that capacity.
Okay.
I have a colleague, just last comment, sorry. My colleague is a surgeon. He has no risk factor for ischemic heart disease. Developed 3 months ago COVID-19, and he recovered totally. 3 months later, he developed acute myocardial infarction with extensive anterolateral infarction, and no risk factor at all. And we think that the only explanation is post-COVID. Yes.
Right.
Yeah.
Right.
Thank
That's
you.
very well known. But also remember one thing, that, and which is why I always push for autopsies. Autopsy studies show in acute myocardial infarctions, only 60% have thrombosis, because there is also a component of arterial spasm. And we miss a lot of these cases. And that's why in a lot of these cases, I always recommend that they get CT angios to be able to determine how much clotting there is in their vascular trees. Because there is also a component of arterial spasm as a result of the inflammation that we're going to be missing also. That's why in the past, when we used to do cardiac catheterizations, we used to have people coming in with acute myocardial ischemias, but yet their coronaries were completely clean, because there's also a component of spasm that we have to be monitoring for.
Okay.
Okay, thank you.
Okay, thank you so much. Another question from Dr. Wazan. Dr. Wazan, you have another question?
Yes. Yeah, Dr. Castro, I live in the States, and then it's so random when they tell people to have mask orders without instructing them how to wear a mask. I'm completely against the cloth mask. I think a lot of people are getting sick because of this cloth mask, because they like inhale and it gets wet and the virus get on the top. This mask never been washed for maybe a month or so. They keep it in their pockets. They put it in their, whatever car and their bags, and then they get themselves sick. So I really did contact everybody at the CDC, the governors. They have to issue only medical mask, and this has to be, disposed after every single use. So what do you think about this? I think after the mask orders, a lot of people are getting sick because of the mask. It's like you're putting the virus right on your mouth and inhale it.
Well, again, from a clinical point of view, excellent commentary. The unfortunate part of it is that about 15 years ago, I gave a talk in Washington on healthcare rationing. And one of the problems that we find to be done, and we can't do it, then we just tell people it's okay, you're going to be fine. And so with the shortages that we had initially had with the face mask, then it was kind of like, put this on, it should help. That's why I always teach people, listen to the adjectives that people use. Most likely, probably, should be able to. And I agree with you 100%. That the cloth masks are not good. They should not be utilized. Studies have been done with the regular medical mask, and that every effort should have been and should be at this point that everybody should have access to these masks. There's no reasons why they shouldn't be.
Okay, the last
Dr.
question.
Salman, you're on mute.
Okay, last question.
You said just that people should wear. Sorry, Carol. No, not a question. I mean, this is important comment about
yes.
the.
Okay, no problem.
clothes masks. So it's like Germany for
care. Because we're observing an increasing number of children who are present PIMS TS, if you like. But I'm sure Professor Salman is aware as well with the myclevine and others. So a number of the clothes, as we routinely now do echocardiograms, because these children, by the way, present also late, not like Kawasaki, while young.
Right.
They were noted to have myocarditis as well, and I wonder whether the colleague who Yusuf mentioned, whether he has some residual myocarditis and end up with the myocardial infarction. We normally we use the same protocol of the KD to do serial echocardiogram, and if we are not sure, we do even CT scan.
Okay, thank you, Dr. Majid. The paper review for acute leg ischemia only, not for the heart problem. They review acute leg ischemia in 400 COVID-19 patients.
Yeah, I know. You mentioned your colleague with the MI story.
Oh, sorry. Yes.
Yeah.
COVID-19 and subside completely.
Well, this completely thing I have all point for cardiographer.
At that time, not.
Do ejection fraction.
Because nothing with the heart, no chest pain, no any complaint at that time, I think. I'm not sure, but I think so.
That's okay. Salman, good question about the long sleeping in adults who recover. No, it is very well known for some time, fatigue syndrome following viral infection. I know we have unique virus here. Oh, interesting game with us, okay? But chronic fatigue syndrome and those who are, and I deal with teenagers who again happy and think, and now they sleep 12, 14 hours a day. So it is.
Yes.
So, but of course, we're talking about children here. We more studies.
Absolutely. You're on mute, Dr. Sanya.
Thank you.
So again, yes, Dr. Salman, sorry.
I think if there is no question, I just want to go back to the mask.
Okay, my colleague, there is any question to finish this webinar? Excuse me. There is any question, the last question to finish this webinar, any question from panelists?
Yeah. Well, the technological mask or medical mask is actually not available for everyone. And taking the point of anything that, protect you or minimize the transmission should be adopted. But people using cloth mask should be advised to wash it every day, and they have multiple of these. And if they have filter, it will be a great benefit. If we restrict it to surgical mask, especially in poor countries, low and middle income countries, it becomes mission impossible. And this is an important point because the unit cost of these is okay in Sweden and Germany and Britain and United States. It is something beyond affordability for many people around the world.
Okay.
No, I
okay.
agree with you. I agree with you, and I think that again, and there's always an underlying concept of as you mentioned, not everybody can afford it, and this happens to also highlight the issue of rationing of healthcare that sometimes does occur behind the scenes.
Yeah. Thank you very much. Thank
Okay.
you.
Okay.
Everyone.
Thank you so much for all.
Thank you, everybody.
Yeah, it
Thank you.
Thank you.
was
Bye-bye.
really a very informative talk and lecture to improve our knowledge about COVID-19 thrombogenicity. We will meet you in next webinar with a new trending subject. See you and stay safe, please.
Good to see you all.
Thank you, everybody.
Bye-bye.
Thank you,
Thank you.
everybody.
Great to
Bye.
see
Bye.
everyone.
Bye-bye.
Thank you.
Bye. Bye-bye.